Good afternoon, everyone. We're pleased to resume our grand rounds, and this time we're presenting something from our center. So the speaker for today is Dr. Amr Al-Sammak. He's a graduate from Alexandria University, Faculty of Medicine in 2001, and then he obtained Masters in Internal Medicine and Kidney Diseases in 2011 from the same university. And he joined our hospital, Mubarak Al-Kabeer Hospital, in 2012, and since then he's been working in the nephrology unit. He's been in charge of the advanced chronic kidney disease program in our center, and he's the moderator of our pre-dialysis clinics. So, Dr. Amr, please.
Thank you, Dr. Yusuf. Good afternoon, everybody. Today we'll discuss our pre-dialysis program. Transition from chronic kidney disease to end-stage renal disease is both physically and psychologically demanding. KDIGO recommend to start preparation for renal replacement therapy in stage 4 with GFR less than 30. But most renal physicians start the pre-dialysis care in GFR 15 to 20 with expectation to start dialysis within 6 to 12 months. Because these patients will require professional teamwork that will attend to minimize the rate of progression, dietary intervention, active management of complication, including anemia, mineral bone disease, and malnutrition. Pre-dialysis counseling, like choice of dialysis modality, pre-dialysis and the pre-transplantation information. And for sure, preparation for transplantation, formation of dialysis access. So, we recommend surgical review at least 6 months before starting dialysis. And finally, initiation of dialysis. Now, there is a very important question: when to start dialysis? Before answering this question, we have to know that we cannot depend on any calculating method to estimate the GFR in advanced renal failure. Despite the MDRD is useful to identify chronic kidney disease and also to estimate the rate of progression, but it shouldn't be used to start dialysis. Now, when to start dialysis? Starting dialysis in the patient with GFR less than 15 should be considered when there is one or more of the following signs and symptoms, like uremia, inability to control hydration status, inability to control blood pressure, a progressive deterioration in malnutrition. But we have to remember, for high-risk patients like diabetic or rapidly deteriorating GFR, they will need close supervision. But if supervision is not feasible or uremic manifestation difficult to be detected, it's better to start dialysis. On the other hand, for asymptomatic patients, it's better to delay dialysis to allow preparation, planning, permanent access creation rather than temporary access. Now, Dr. Yusuf will join us to present our pre-dialysis program.
So I just have 2 slides just to explain the structure of the program that we launched. The advanced CKD clinic consists of 4 clinics, actually. The patient first comes to the nurse first visit clinic. When he comes to the pre-dialysis nurse or the nurse educator, she will take all the important information, medication history, past medical history, and she will do the required labs, prepare them all in a flow chart for the next visit when the doctor is there. And that will be in the educational multidisciplinary protocolized clinic. So that clinic, which we're going to show you a video of, consists of a doctor, nurse educator, dietitian, and a social worker. And the patients will receive 5 sessions of education and then discussion about the future renal replacement therapy options. And by the 4th, 5th visit, the patient would have decided what's the best option for him or her, and then we will basically refer the patient to do the required workup for that. So at that time, we can also refer the patient to the other clinic, the Access Clinic. And that clinic, we examine the possibility and eligibility for vascular access or the eligibility for peritoneal dialysis. And also, we can assess them for renal transplant from a surgical point of view. So they finish their surgical assessment, they come back to the educational clinic, and then if they finish their 5 visits and they've decided what's their option for the future, then we're just waiting for dialysis to be initiated or for transplant to happen. So then we refer them to our sister clinic, which is the follow-up advanced CKD clinic, and this clinic is run by Dr. Amr. And from that clinic, we hope that we get our patients started on peritoneal dialysis or hemodialysis through a fistula, or preferably the best choice is a preemptive transplantation. So that's how it works. And I'm just going to show you our protocol for access, for creation of an access. So we've developed an algorithm. It's a little bit complex to understand, but I'll take you through it. So on the left, this is when the patient is stable and he's coming from the clinic. So we know these patients. We've been seeing them, following them in our nephrology clinic, and then we refer them when the GFR is below 20, we refer them to the advanced CKD clinic. If their GFR is less than 10, then we don't refer these patients to the advanced CKD clinic, but it's the responsibility of the treating doctor to create the access through the same pathway and the same resources, but they don't go into the advanced CKD clinic, the educational clinic. If they go to the educational clinic, then as we said, they go to the access clinic to be assessed. If we decide what type of access we're going to create, then they get anesthesia clearance, electively also in the OPD, and there they will have a consent, signed anesthesia clearance, and they basically fill the dialysis access form. That form contains the important information for the one who will do the procedure, so the INR, the platelet, some information about the access history and the veins. So that form, when it's signed and ready, then all the papers go to the Access Senior. Access Senior is the senior registrar who's running the dialysis during the dialysis rotation. The Access Senior will decide where to put the access. So we can tell the Access Senior that we need a perm cap for this. The job of the Access Senior is to decide where to do this. So he can do it in the OR or in the interventional radiology, IR, or in Hamad Al-Isa, OTC. The Access Senior is the manager of all accesses. He will schedule all patients, and he will be able to decide the priorities, and he takes care of booking the patient. On the right-hand side, these are patients coming from the wards. So these are patients who presented to the ER with emergencies and they needed dialysis, crash starts. We hope we don't see many of these, but they will keep coming. So the ward doctor starts dialysis as an emergency through a temporary line, and then the next day the ward doctor should call the inpatient access team. The inpatient access team is a mobile form of the advanced CKD clinic. So this team consists of a nurse educator, a PD nurse, a social worker, and the ward doctor. They will come, they will spend 20 minutes with the patient to convince him or her that they need a native access. So either a fistula or a peritoneal dialysis catheter. And our goal is not to discharge any patient who started as an emergency without a permanent access, either a fistula, graft, or a peritoneal access. And that's also is being booked by the access senior. So that's all what I wanted to show you. Maybe I can add one more point. In IR, we are aiming to take all the perm cats and do them in IR, so we can free spots in the OR list for fistulas and grafts. But the problem that we face is if there are unstable patients, they have to be done in OR, or if they can't afford the fees for IR. These two obstacles are preventing us from putting more cases of perm cap in IR. So those patients will go to our OR list also.
Thank you, Dr. Youssef. To know more about our pre-dialysis clinic, I let you to see this video.
حين يصل مريض الكلى إلى المراحل المتقدمة من المرض، يصبح اختيار أحد البدائل العلاجية ضرورة لابد منها قبل حدوث المضاعفات. ومن المهم أن يكون المريض على اطلاع كامل على خياراته ليتمكن من اتخاذ القرار الصحيح بشأن البديل العلاجي الأكثر ملائمة له. وقد دشن مركز مبارك العبد الله الجابر الصباح لغسيل الكلى عيادة جديدة لرعاية المرضى الذين يعانون من مرض الكلى المتقدم. تقدم هذه العيادة نموذجاً رائداً في الرعاية الصحية لمرض الكلى المتقدم، حيث أنها عيادة تخصصية تثقيفية متعددة التخصصات، تقوم باتباع أحدث التوصيات الطبية والمعايير العالمية في العلاج. في يوم زيارة العيادة يتناوب على المراجع في مكان واحد طاقم طبي مؤهل يشمل أطباء متخصصين وممرضي تثقيف، بالإضافة إلى أخصائي التغذية وأخصائي الخدمات الاجتماعية والنفسية. تقدم العيادة برنامجاً تثقيفياً معداً بعناية لتوعية المرضى عن طبيعة مرض الكلى والمضاعفات والأعراض الواردة الحدوث، وتقديم نبذة عن خيارات العلاج المتاحة كزراعة الكلى والغسيل الدموي والغسيل البريتوني. كما يشمل البرنامج جولة في أجنحة الغسيل الكلوي في المركز وشرحاً عملياً عن كيفية إجراء الغسيل البريتوني في المنزل. وتتاح للمريض فرصة اللقاء بمرضى سابقين لشرح تجربتهم عن البدائل العلاجية المختلفة. وبانتهاء البرنامج التثقيفي يكون المريض قد حدد خطته العلاجية المستقبلية بنفسه، وحينها يقوم الطاقم الطبي بتهيئة المريض طبياً بمساعدة الأطباء في مركز حامد العيسى لزراعة الأعضاء. فيتم إجراء الفحوصات اللازمة مبكراً وتهيئتهم لزراعة الكلى أو الغسيل البريتوني، بينما يحول المرضى الذين يختارون الغسيل الدموي لعمل الوصلة الشريانية والوريدية مبكراً تمهيداً لبدء الغسيل بشكل مخطط له، وتجنب الحاجة للغسيل الطارئ عن طريق القسطرة الوريدية ذات المضاعفات الكثيرة. تمثل هذه العيادة التخصصية نقلة نوعية في مشاركة المريض في تحديد الاختيار الأنسب له وضمان انتقاله إلى المرحلة الجديدة بسلاسة ودون مضاعفات.
Okay. Now let's present our statistics over last 2 years. Total number of our patients 121, 68% male, 32 female. Most of our patients above 50 years old. As you know, our criteria in pre-dialysis clinic, GFR, it should be within 10 to 20. And I think most of our doctors follow this criteria. GFR between 10 to 20, 100 patients. 17 patients with GFR less than 10, and only 3 patients was above 20. Okay, regarding ill conviction, despite the hard work and dedication from our team, still, most of our patients were not convinced. I know it's so difficult to convince the patient, especially for starting dialysis, but later I will ask you, what's your recommendation to improve this percentage? Transplantation, 20% of our patients completed transplantation workup, but still we have 2 challenges, time and the age group with multiple comorbidities. Now, outcome, or on the other hand, our achievements. 48% of our patients still in close supervision, 2% with well-functioning AV fistula, 14% already started peritoneal dialysis, 12% started hemodialysis, 7% with permanent catheter, and 5% with well-functioning AV fistula. 3 patients underwent renal transplantation, but 17% didn't complete our pre-dialysis program. I think this is very, very important percentage. Only 2% mortality rate with non-nephrological cause. One, diabetic foot and septicemia, and the other one, cardiac issue. Again, one of our achievements, we reduced the emergency admission to only 2%. Now, our recommendation, we must work together to change the concept that hemodialysis is better than peritoneal dialysis. It should be taken into account that the majority of patients will be symptomatic and they need to start dialysis with GFR in range 9 to 6. So, we suggest early referral to our pre-dialysis outpatient clinic to implement the chronic kidney action plan. So our recommendation to increase the criteria from 10 to 20 to 15 to 20. And for sure, our goal, preemptive transplantation. Thank you so much.